which has a number of different streams of interest in terms of the research that we do. So primarily looking at how to support communication skills in healthcare interactions, what goes on between health professionals and patients. Also looking at experiences of care, caregiving and care receiving, and what does care mean to people. And then more recently really started to delve into, well, how do students learn how to communicate in the health sciences, and finding ways of supporting students, because this is actually a very challenging skill to learn. So really developing a subtle stream over the last couple of years, got quite interested in telepractice and simulation. So that's really become a strong interest. And then another theme is really delving deep into qualitative methods. So the methods that I use are primarily qualitative. So just to give an overview of where we're at with SIM in our department. So we initially started work actually via the audiology field. So one of our colleagues, Nabila Nagdi, hooked up with the medical school SIM lab, which is quite well established. And just to say, so we're a health science, but we're in humanities at Wits. So we're separate from the medical school. So we joined forces, particularly with Nabila Suji, who's a familiar person to many of you, and started a prac around newborn hearing screening simulations back in 2020. And then somebody in the department decided, let's get a sim lab going, and they applied for money, and we got a whack of money out of council, and opened a high fidelity, high tech sim lab in 2022 in our speech department. So that has ICU rooms, a NICU room. It has various mannequins with varying levels of fidelity and functionality. We've got different audiology simulators, and we've got task trainers as well, particularly for the audiology students to practice doing things like otoscopic examinations, etc. So we opened the sim lab, and then we said, now what do we do with it? And how do we get sim going? And this is really where Kim has come into things in a big way, and I'm so glad she could join us today. So Kim has been spearheading the simulation work in the department, doing a PG dip in sim, trying to get the sim integrated into the curriculum in a big way. And it really has been about kind of dipping our toes, but also finding our feet. And figuring out, well, what do we do with all this beautiful equipment, and how do we integrate it and get our heads around new pedagogies? Because it isn't just a case of, oh, well, let the students play with the mannequins. It's a whole new way of learning and teaching and doing things. So this is just a picture of some of the newborn hearing screenings. So what they would have is two students paired up, audiology students, and they're working with a baby mannequin. And then there's an SP who's playing the caregiver. And then there would be various scenarios around maybe the child's had meningitis and is at risk for hearing loss. And then often the SP will play a role of not being able to speak English, or having difficulty with transport money or something like that. And so the students have to then navigate the technical side of things with actually performing the newborn hearing screening, inserting probes into the baby's ear, dealing with the equipment, etc., handling the baby. But they also have to then interact with the SP as caregiver. So, and that's quite a lot for them to juggle. And Nabila Nagdi has been running these with Nabila Suji for a number of years now, and refining how these pracs are run. And then in our sim lab, this is just a sample of pictures of what goes on in the lab, the kind of equipment that we have. There's Kim there in the white shirt. We also have video recording functionality. So it's a really great space for giving students some opportunity to get used to hospital spaces and NICU spaces, and then also working with the mannequins. And what we've done is run all sorts of sims. So Kim integrated sim into her head injury course this last block, and the students had, one of them was dressed up as a patient, and what she'd done is she had introduced a patient case in the lectures, and then that was carried through into the sim, and then the students had to do a mock assessment. So I think one of the big challenges that we've had is that there's an assumption, there was an assumption, certainly when this all was set up, was, oh, the mannequin can just fake a stutter or a speech disorder. And not really. So it's been a bit tricky to kind of figure out how we use these things and these sim types in speech pathology and what might work. So what I'm going to just talk through today is some of the research that we've been doing, starting with a survey that we did across the country, then a scoping review of simulation in speech therapy literature, a similar one in audiology, focusing particularly on counseling and communication, some of the work we've done on peer role play sessions, and then we are in progress with trying to analyze. We've got over 50 videos of newborn hearing screening simulations, which is a huge amount of data to get our heads around. And we're still trying to figure out, well, what do we analyze and what do we look for in this data? And then Kim is busy with Nancy Barber and Nabila Suji on analyzing debriefs of team discussions using duo-ethnography and really reflecting in a very deep way on being a facilitator and reflecting on the sim itself. So this was the survey that we conducted. Amisha and I conducted this a couple of years ago. And what we did was we sent surveys out. We got responses, or we got participants from 5 South African university departments. And we were very disappointed. We put in huge effort with this study, and we only got 12 responses. 3 educators and 9 students. And we thought, what is going on here? This was well advertised. We had departments on board and just such poor response. So part of that is research fatigue trends. But part of it, I think, is also to do with how people view sim, what's actually happening in terms of sim in the profession. And what we really saw is that COVID had forced simulation, but it was implemented very haphazardly, limited preparation and guidance, and some of the universities just stopped using it after COVID. So when we looked at the types of areas and the number of universities, very kind of erratic, like one university here and there, but actually quite a lot of different types of pathologies and clinical areas that were being covered through sim. When we looked at the types of activities that people were reporting, you can see down the bottom of this graph a really heavy reliance on things like role play and case studies, rather than the high fidelity types of sim, like working with mannequins or standardized patients. So from the survey, although we had a very small number of participants, we were able to conclude that sim really seems to be in its infancy. That people in the profession are not really knowing. They don't really know what they're doing with sim, and it's very shaky in terms of how it's being implemented. Also, a very big focus on low fidelity sim, which students were often left to complete in their own time. Like off you go and do a case study or use SimuCase software. That supervisors really didn't know what they were doing with marking. Students were very dissatisfied because a lot of these low fidelity sim types are obviously not good in terms of realism. And students really felt unable to engage with sim in a very realistic, empathetic manner. So another study that Kim and I have been killing ourselves with, like, do not do a scoping review on sim. We've got too much data here, and we're busy now with major revisions on this paper. But it's been very interesting. So we ended up with 53 articles, only 1 Global South article from Chile, nothing else, nothing from South Africa. So these were studies looking at some kind of measurement of outcome or perception of sim by students. Some clinical areas have a lot of sim support, like dysphagia or swallowing disorders, adult neuro, stuttering. Others have virtually nothing. It's like one study for cleft palate, which is actually a very hard disorder to find for students to practice. what we saw as well was there's a real need for careful planning and scaffolding and feedback to students. There was very little on long-term acquisition. There were 2 studies on long-term acquisition of knowledge and 1 study on looking at student perceptions 3 months later and confidence, but nothing on how the skills that are learned in a sim actually impact long-term skill acquisition. Often also very, very poor description of how the SLE is actually embedded in the curriculum, and very limited perspectives from clinical educators and SPs as well. So just to give a little bit of insight on the audiology study, so this one we really wanted to look in a detailed way at what is being done, particularly for communication and counseling, given that this is very difficult to train and it's difficult for students to acquire these kinds of skills. So we looked at how SIM is being used for communication with audiology students. We found 17 articles, same story. There's nothing from the Global South. Mostly they were using SPs for training communication, which is appropriate, but there were some weird things as well, like really unusual types of SIM being used that we felt, not necessarily a good fit for this kind of skill. In general, we found that participants reported positive experiences, but it really wasn't clear whether there's a benefit to simulation versus traditional teaching for teaching these types of skills. And very importantly, we noticed in this review that students struggle tremendously to integrate technical and communication skills. And we've seen this in other studies. I've been involved in a study looking at peer role play with medical students. They really struggle to get the information right and the counseling right and integrate the two. In the sim, they struggle to do things like manage the baby mannequin and communicate with the SP as caregiver. So those kinds of skills are quite high level skills. Yeah, I think I meant to say mannequin plus SPs here, not SLEs, but you get the picture. So we really need to think about the scaffolding and the grading of the types of tasks that we are giving to students. Then we study looking at peer role play, which interestingly in the literature that we've been looking at, certainly in the speech pathology arena, peer role play is often not typically counted as a sim type, but yet it's often used. So in audiology particularly, it's a case of, oh, the patient didn't arrive today, so, oh, the students can quickly practice on each other. They can practice doing the hearing testing on each other, often with very little preparation or debrief or anything, just kind of thrown into the situation and off you go. And I know that was certainly something that was standard practice when I was a student and learning audiology skills as well, was off you go and test your classmates. So we video recorded peer role play sessions, and then we interviewed the students in the role of the audiologist and as if they were the patient as well, which was a very interesting exercise, a bit messy, but some useful results. So what we saw was that students were very, very hesitant with their responses, like very unsure if what they'd done was okay, if it was enough, weren't sure about their own skills. And very definitely students are saying that peer role play is really different to communicating with a real patient. It's a different experience. They really struggle to take on the patient's perspective and put themselves in the shoes of the patient. And this was just a very interesting quote where a student said, I don't think I paid as much attention to nonverbal cues or body language, mostly because I felt it wasn't necessary and it was something from a script. It was standardized. So they'd been given a scenario like, okay, the student playing the patient is going to pretend they have this kind of hearing problem. And so the realism wasn't there anymore. And they really struggled with this, which said to us that we need to be paying more attention to something like peer role play. And certainly the other study I was involved in with the medical students, they also struggled tremendously with peer role play. And kind of putting themselves into the patient's shoes and portraying a patient in a realistic way. It's something that's not easy for students to do. And I think we often just assume it. And I know, just a side note, we've had a big discussion apropos our Viva exams, our oral exams, about whether or not it's appropriate to ask students to role play in an exam situation. And the decision ultimately was no, it's not fair to them. They don't have preparation. Also need to prepare the clinical educator. Just doesn't work. So it needs a lot of prep and planning. So those were four studies that we've done so far. And I think from all of these studies, some of them literature-based, some of them empirical, there are a lot of caveats and considerations that we've learned along the way. One of the things that we've really had to grapple with, and I know we had big discussions about this at the SAAHE conference as well, is that some professions, for example, medicine, is perhaps far more focused on clinical skills, like can the student perform a pap smear, versus what we are doing in speech therapy and audiology is often much more integrated. So something like the technical skill of testing the baby's hearing and talking to mom, or doing an assessment with a brain injured patient. So it's a far more complex kind of skill and much more integrated, and lots of skills being integrated into one scenario. So we've really grappled a lot with the issue of whether SIM is fit for purpose and what type of SIM is fit for purpose. And how do we scaffold the SIM that the students are doing in a way that they can cope with? Also thinking about realism. So it's been lovely to see in some of the SIMs that we've run where students have been asked to play a patient. Sometimes they've arrived like fully dressed up like an elderly person or in a hospital gown. And they've really engaged with it very well, versus other times where they haven't had that prep, like the peer role play study. They've just been thrown into it. They don't actually have that ability to engage with the realism in the same way. What we've also noticed is that a lot of the studies, certainly in the literature reviews, are terrible in terms of how they describe how the SIM integrates with the broader curriculum. Often there's just no information at all. No information either about the planning, the pedagogy, the debrief. And so those are really, really important processes to consider and to bring into, firstly, what we're doing with SIM practically, but then also any kind of research and any articles that we're writing up on our SIM. We really do need to make sure that that is thorough. We've also thought very carefully about how we use SIM. So there was an idea floated around again with the Vivas, the oral exams, of, oh, we can just get them to do SIM and do OSCEs. And actually, we've come to the conclusion you can't do that with our students. It doesn't work for the types of tasks and the integration that we're looking for. The other thing is you can't throw students in the deep end and say, okay, we'll use SIM for assessment if they haven't had opportunities to use it formatively for learning, for making mistakes, for having that safe environment to have that experience of practicing. And so that's really been very important. And a lot of the work that Kim's been doing has really been around allowing students to explore and experience, and trying to always bridge this theory practice gap in the lecture. So bringing SIM into lecture time rather than as a separate clinical prac, which I think has been really important to do. Yeah, so really thinking strongly about developmental hierarchies and scaffolding. And this diagram from the SIM zones work, I think, is really key in thinking about how to scaffold and where do you start with students and where do you take them to across years of study, across a year of study within a course. And something that I'd really like to do in the future, I think it's going to be very tricky to do, but I'd have to get my head around it, but trying to also think about this diagram, particularly in relation to communication skills training. Where do you start And then how do you build up the layers of complexity so that you get students to a point where they're actually competent and they've had lots of scaffolded opportunities along the way to practice these kinds of skills. So just to give a bit of insight into where we are going from here, really thinking about stronger embedding of sim work and SLEs into the curriculum for audiology and speech. We've got constant nagging from the school administrator who's saying, why aren't you using the sim lab more? And we're pushing back and saying, but we need to do more research. We need to actually do this properly. We have to get our heads around pedagogy. It's not just about throwing the students into the sim lab and saying, off you go. There's such a careful process here, figuring out how to use some types of sim, what's the best fit, etc. So we are, Kim and I and a couple of other colleagues are really keen to get a SOTL research cluster going that focuses particularly on the scholarship of teaching and learning for sim in our department. We've also set up a huge project for next year with interprofessional SIMs. So they did a trial run this year. So us hooking up with other health science departments. So this year they did with OT and physio. Next year, I think it's going to be crazy, but we're going to try with medicine, pharmacy, and sports science as well. And social work, I think, is also in the mix. So, and we're going to try and record some data and get some empirical studies of real-time teaching activities. This is something else that we've really noticed in the literature. A lot of them rely on Likert scales and tick box quantitative surveys for evaluating sim rather than actually looking at recordings of sim sessions and how students learn, how do they communicate with each other, how does the facilitator mediate the sim process, and that seems to be lacking tremendously in the literature. And it's not easy research to do, but that is where we wanting to head. So Kim's already done a little bit of preliminary work on this, and we're hoping to take it a bit further next year with this IPE project as well. So lots of work on the horizon here. Not always easy work, as I say, but you know, it has to be done very carefully and in a very considered way. So it's also been about getting our colleagues' heads around the fact that this is not just a quick fix or a throw in or an add-on quick kind of thing. It really is a whole new pedagogy. Yeah, so that's it from me. Very happy to take any questions, and you can get hold of me on email if you would like to. Thanks.
Thank you so much, Jennifer and Kim, for the work that you've been doing. That was quite a interesting and thought-provoking presentation. And I must say, I really value, and I know that most of you who attended the conference know that I value scaffolding and the pedagogy of simulation, because I do feel that often that's something that gets lost when we are forced to just implement simulation within our curriculum, which is one of my huge pet peeves. But that's a story for a different day. Colleagues, I'm going to open the floor. If you've got any questions for Professor Watermeyer, please, you can just raise your hands.
Yeah, just to say, Karine, we were very inspired by your SimZones presentation at SAAHE because I'd never really come across it before. So that's where we started to get into that work in a deep way.
Okay, well, that's awesome. I see with Sandra, your hand is up. You can shoot.
Thank you. That was a great presentation, Jennifer. Thank you for reviewing all the work that you've done. Less of a question, maybe more of a follow-up comment, because you introduced the idea of role-playing with trainees, and just wanted to share some additional advice around that. So there has been some commentary around how to use that role play. So there are often mistakes made where junior people are asked to play a senior role with the logic that if they can role play a most responsible physician or a lead nurse, then they can imagine themselves in that confident leadership role. But what is often overlooked is the potential for stereotyping and for people who are not, as you said, not prepared, not given the right amount of time and training to actually develop into that mature leader. They will just draw on the little bit of information that they know, which ends up, you don't want a medical student stereotyping the role of a nurse, for example, in an education setting. So just a comment on that, in terms of the importance of preparing them. So.
Thanks, Sandra. Yeah, absolutely. I agree with you. We did come across one study in our review, which also talked about how students respond differently, depending on, so that this was a study where they had a CE, a clinical educator, role playing different doctors, nurses, therapist, patient, and students responded very differently and felt quite anxious when they were trying to talk to a doctor. We also saw some strange things, like there was a study that we came across where a clinical educator was playing the role of a child, which is also just, it's such a mind bender in terms of realism, and I'm not sure how that might work. So yeah, I think the role play is often something that is just so badly done, unfortunately, and students are not adequately prepared, and clinical educators are not prepared either. I was an examiner on one of our oral exams recently where we were trialing more of an OSCE approach, and one of the questions, which I hadn't been prepared for, was, what would you say to the dietitian about the patient with swallowing disorders? And then the students started talking to me as if I was the dietitian, and I didn't know how to answer them. And I had to say, look, I'm actually not a dietitian. I don't know what to say to you here. Well done for trying to role play, but like, oh no, it doesn't work. So yeah, it needs careful thought. So thanks for that.
It's perfect. Thank you, Sandra. I think that actually links quite nicely. I read an article the other day where they say students, especially in simulation, if not integrated correctly, students learn how to simulate. They don't necessarily learn how to do the skill. And I think the student responding to you as the dietitian is exactly that, because they simulate it. That's what they learned, is how to simulate.
Absolutely. Yeah, and one of the points that we're making in this SIM paper, the review that we're writing up, is the difference between confidence and competence. That a lot of these studies also look very strongly at, oh well, the SIM increased students' confidence, but that doesn't necessarily translate into competence or else confidence in the real world doing the skill. And so I think a lot of these studies really need to be interrogated in terms of those aspects and the claims that are made around how wonderful they are and how they help students so much. And we need to be thinking a lot deeper about how students learn via SIM.
No, definitely. And I wish that most faculty can also, take that stance, but we're getting there. At least we are a few that's advocating for that. So that's good. Seeing as we've got no other questions, Jennifer, thank you so much once again for joining us, for sharing the journey that you've been on, for challenging our ideas, especially within research in a culture where it's publish or perish, which is interesting.
Yes.
Then to all the delegates that are joining us, it might be a little bit of a strange request. But can I please ask that you switch on your camera? I want to take a picture. Normally when we go to conferences, we'll take like a group picture. So I want to take a group picture of us. So I don't know if you need a quick 3 minutes to fix your hair. Hi, Alzana. We're going to talk about the conference for next year, which is something exciting that I want to share with you. And Alzana is the host for next year. So I'm glad that she's joining us. Okay, so we're just waiting for Nicolene, Tato, and Lynn. Hi, Rian. I'm glad that you joined us. He's the third SIG person. All right, so I think I'm going to take a picture. Oh, there's Tato. I'm assuming that. Oh, Nicolene, I'm sorry. We'll just put I'll edit you in somehow. I don't know. We'll just put a smiley face there. All right, so let's smile. I'm going to do a screenshot. Lynn, I'll put something in there for you. Oh, there you are, Tato. Hi, Tato. All right, so let's smile. Let's do 1, 2, 3. Let's see. Let's hold on to see if it actually worked. Yes, I've got us. So that's perfect. Thank you, everyone. You can switch your cameras off again. It's fine. I'm so glad. Well, it is at the end of the day in South Africa, so majority of us are probably on our way home or already home. Sandra, I'm assuming you are early in the morning at the moment.
Yeah, it's just coming up to 9 a.m. So
okay, so it's not like 7 a.m. in the morning. And you are in winter, am I right?
Yes, yes. So I just started to feel a chill because the heat hasn't quite gone on yet. So
okay, so we are going to
sending
you some of our beautiful heat that we are currently experiencing. It is excruciating summer in South Africa, so it's very warm. So colleagues, I would like to introduce to you Sandra Monteiro from McMaster University in Canada. I'm also going to allow her to introduce herself. Like I said, I don't want to butcher her CV at all. So Sandra, the floor is all yours. Let's see first if your presentation is working. Perfect. I can see it from my side.
Okay, that's a slide. Okay, great.
Perfect.
Thank you.
Enjoy.
Again, thank you. This is such a warm welcome. So that does help with the feeling of warmth over this cold. So on this slide is actually quite a bit of information that I wanted to just unpack for a moment. So I usually try to minimize my introductions because there's often more information when I get to talking about the presentation. So I'm as I mentioned before, I work at McMaster University, and I'm attached to a program called Merit, which is housed within our Faculty of Health Sciences. And our group is committed to helping our clinicians build capacity in education, assessment, research, scholarship, and I'm also a director of scholarship at our simulation based learning center. And so this logo that was created for me represents a community of practice that I chair called Insight U. It's sort of an ad hoc thing, but in our institution and maybe potentially in yours as well, simulation happens in all corners of the schools and the classrooms and the hospitals, and we have many distributed campuses and many hospitals in a big city. And so while we do have a dedicated center within our main campus or central campus site, there are smaller pockets of simulation that are perhaps even better funded than the central location, and others that are mannequins that are sort of stored in a closet and brought out for updating people's clinical skills. And so bringing a community of practice together, I thought could serve to reduce that sense of isolation, because that's what I'd noticed is there would be, a single faculty member sort of over there in one department doing simulation the best that they could with their learners. And then there was all this equipment, rather pricey equipment, stored in the central campus Center for Simulation-Based Learning. So we're trying to keep those conversations going. So it's really good to see that you're also doing something similar here with this event. And the theme that you've got on choosing wisely when designing simulation scenarios speaks to me, because this is a line of scholarship that I've developed myself with my colleagues, and we've published on some of our thoughts in that. And so I will weave some of that through my story today. The title that I've chosen to represent what I'm going to talk about is the competing expectations between the educator and the trainee. So I will, in the next slide, I will just unpack how I got to that topic. So my approach today with this presentation is to focus on some of the conceptual and theoretical models behind the pedagogy of simulation-based education in terms of best practices, but also to incorporate some principles of how people learn So my PhD is in cognitive psychology, so anything related to memory and behavior or behavioral change and learning is sort of in my area of expertise. And that's pretty much the way I see any topic. And so my main focus these days is sort of looking at how theory is applied, and whether what we're doing even at our school in applied settings and practical, in the practical spaces, whether what we're doing is translating the theory appropriately and making the best use of resources. So I just identified two simple objectives that I wanted to work through my talk, which is to lead a discussion about potential assumptions that are made when clinicians design simulated clinical scenarios, and then also move towards some potential strategies that can maybe override those assumptions and then work towards enhancing the value of simulation for our learners. And just a note that I am perfectly happy to entertain questions along the way. I just may not be able to track them if you're putting your hand up or putting a comment in the chat, because my view is pretty limited. So if you want to even just start speaking, if you want to turn your microphone on and start speaking, that is perfectly fine with me. Right. And so Karine and oh, goodness, the first presentation, sorry,
Jennifer,
there was
it was Jennifer.
I'm so sorry. There was an introduction around this idea of constructive alignment. So I just included this slide actually at the last minute. This is some material that's in that I've incorporated in a lecture. We have a Master's of Science in Health Sciences Education program. And I lead the first introductory course that covers topics around learning and curriculum design. And so constructive alignment, at least this model, is one that we introduce to our learners who are full-time clinicians in many different disciplines. And I guess a small promotion note, it's a fully online program, so it's meant to be accessible to people who are fully in practice and wanting to update their teaching skills. And the idea is that there's three simple elements to curriculum that an educator should think about when planning a course or a program. You know, what do you want your students to learn? How are you going to support them through careful construction of teaching and learning activities and opportunities for them to practice what they've learned? And then how are you going to design moments of feedback, coaching, mentorship, and guidance, and moments of assessment to ensure that they are sort of learning what you've taught them. And then there's also this other set of notes that is taken from a paper by Myers and Nolte around, and I'm going to call these sort of common statements around curriculum design that I've seen strongly influence decisions in the simulation space. And they are quite intuitive, I think, and quite convincing to most clinician educators. I want to come back to that list a little bit later. But the importance of something being authentic. So Jennifer, you commented on how students are often drawn to that and feel disappointed when the simulation feels too artificial. And that point 3, that it should be education should be engaging, or the curriculum should be engaging in some way. I think a lot of that is also reactive to what students ask for, that they don't want to show up to a boring lecture, perhaps. They want something that's interactive and potentially fun. There's a bit of psychology behind that, the draw towards something rewarding. So anytime we experience something new, there can be a bit of a rush of dopamine, which makes us feel pretty good. And so I just point that out because it can lead us down some potentially incorrect assumptions around always having to develop something new for our learners just to keep them engaged. And how we balance that, I think, is what makes all of this very difficult. And balancing that with a budget as well, which brings me to the concept of choosing wisely, which is another model or framework that I've incorporated into some recent scholarship. because, and so I've got on here just a summary of what the original Choosing Wisely concept was focused on, which was to encourage people to have open, transparent conversations about the costs of tests or imaging, diagnostic tests, for example, or specific treatments. Particularly when those have very little impact or value for the patient and may just be, an expense not worth taking on. And so what I found interesting about this idea for simulation was to kind of modify that slightly so that we're talking about choosing wisely, and focusing on the balance between resources costs to the institution and the potential for impact on the learners and the learning outcomes. So I'll come back to that as well. I just wanted to highlight the constructive alignment and choosing wisely frameworks that are underlying my talk today. And both of those concepts that I've incorporated are important because amongst the many, many characteristics of simulation-based education, some of which I've listed here, there's certainly more. I've chosen some that I think, the ones that are in sort of a red color, if that is appearing to you in that color, the ones on the left here, these are the elements that often reduce the quality of simulation. So limitations of the high cost of sourcing skilled technicians, content experts to write the scenarios, sourcing specialized equipment, or casting the standardized patients to play appropriate roles. So Jennifer, when you mentioned that a clinician was playing a child, I thought, well, that can make sense because it's very difficult to recruit and cast children into an education setting to play a role and, like to train them to actually get a skilled actor who's a child. So even at our setting, we often have, 19 or 20-year-olds brought in to play an adolescent, like of age 12 or 13, perhaps, but it's very difficult to source actors that can play ages younger than that. So that's often a mannequin will step in for that. And then on the right, I'm not sure if it's coming up as clear, but these 4 points on the right, debriefing, pre-briefing, the ability to repeat and revise clinical scenarios in a simulated setting, I think are strengths, and I would argue are elements of simulation-based education that aren't maybe utilized as often as they should be. So hopefully we can come back to that as well. But yes, on a point on the cost, the reason I wanted to contrast these is debriefing, pre-briefing, repeating a scenario, revising, updating it as needed to customize it to the needs of the learners isn't necessarily costly because the material is already created. It's more about the coaching and focusing on what that learner needs, whereas being drawn into needing fancy equipment or sort of like a theater-based setting or potentially reacting to what students want and believe is engaging content can really raise those costs and can be very distracting away from the pedagogy of simulation. And so coming back to my title slide, this idea of competing goals between educators and learners, I've identified just some that I wanted to talk about. And basically, mostly these are based on my observations and my discussions with clinician educators at my institution. So for example, that the first statement there under the column for educator, I would argue that there are some common assumptions that trainees must determine the objective, that trainees must work hard to find out what lesson must be learned from a scenario that the educator has created. And in some ways, perhaps this draws on even older traditional ideas that an assessment must be really, really difficult in order to motivate learners to do better and in order to identify the best students, which is not the point of education in the health professions. And then I've noticed a lot of clinician educators being interested in incorporating some element of surprise. So that seems to be justified by an idea that clinical practice isn't scripted. You can't necessarily predict what's going to happen next. So simulation must prepare trainees to think on their feet. And then exposure as an assumption is that trainees must experience complex problems. So even just exposing them to a scenario that's likely, even if it's 1% likely, that exposure is important in terms of the assumption an educator could make. And then again, this assumption that the education experience must be exciting and draw the trainees in because they will respond to that. And then that may lead educators to continually create novel learning experiences rather than, as I mentioned before, use that ability to revise and then actually repeat the use of content that already exists. And so I'm happy to discuss some of these points in more detail, but for now, I'll just quickly walk through what are potentially better strategies or strategies that can actually enhance the use of the impact of simulation-based education, which is to be explicit with your trainees. So incorporating explicit learning objectives. We at our institution, learners kind of sign a consent form because we do have recording capabilities, and there may be, within the debriefing sessions, they may be asked to share their thoughts. And so there is a consent form that they sign up front that their behavior, their performance, some of their comments may be recorded for research purposes. But they also complete a survey at the end asking if they remember what the learning objectives were. So sort of a brief evaluation of the instructor that led the simulation. And by and large, the trainees, a common response was they don't remember being given a set of learning objectives. They didn't even know why they were there. So they showed up to a simulation-based training session with no real understanding of what was about to happen. So they get used to this idea that they're just going to show up and everything's going to be a surprise and they'll figure it out in some way. And then they walk away not really knowing the point of that. And so being explicit with trainees is often seen to be much better, and the way to do that is with learning objectives. Priming is related to that, so basically preparing trainees for what's about to happen. And so you could send them reading material, you could send them videos, you could ask them to review content that they learned in a lecture, because they're going to need that in the simulation scenario, and that, again, can help the trainees get in the right mindset. And rather than exposure, I put in practice, which is the opportunity to, not just be exposed to one rather large, complex scenario, but to practice focused skills over and over again, and then kind of level up, which is, if some of you are familiar with the mastery learning model. And so that highlights the role of a coach. Sometimes coaches can be peers, so there can be great benefits in near peer learning and assessment and feedback. It doesn't always have to be that a faculty person has to be there. And then planning. So an idea of involving the trainee in planning some of their own learning goals, identifying their gaps, and maybe just having a conversation about where they are and where simulation can help get them to within the curriculum, and how all of that links together. And I think sorry, just looking at my notes for a minute, make sure I covered everything that I wanted to say here. And so if we were to pay more attention to some of those elements on the right, as opposed to potentially being distracted by or misinterpreting some of these. So I'd listed these before, and this is a publication from 2009, but there are still very strong beliefs in the importance of an authentic, real world and relevant experience. And so clinicians, I find, are often quite excited to draw on their own experience to bring in that authenticity. And this idea that it has to be engaging because students might tune out, and that in order to be engaging, it has to progressively incorporate higher order cognitive processes, which I see is often translated into, just make it more difficult, more complex, more stressful, lots of things happening in a scenario. And particularly for an undergraduate program or novices who are new to learning in healthcare, but also just new to learning in that kind of environment and new to the profession, challenging them in that way could be the worst thing for their learning, because similar to what I was mentioning about the learners' comments at the end of a simulation session, they just sort of leave confused as to what happened, or just continue to enter the room not knowing what's going to happen or why they're there, and that's ends up being their main takeaway. And so some of that is also supported, like the assumptions that educators might make around needing to create complex, engaging, challenging scenarios is also summarized in that point 4, to increase motivation to learn, is sort of a justification for that. So I think that these contrast the previous points I was trying to make about actually being explicit with learners, what's going to happen, and customizing the experience, the education experience of simulation to where they're at. So while authenticity could still be brought into a simulation, it can't jump right into sort of a busy emergency department, setting where there's multiple trauma cases being brought in, and I do think some of our clinician educators really like leaning into their creative writing talents and building in almost like a movie scene, because they think that will be memorable, but it just ends up being very confusing. So just to unpack some of the assumptions that I mentioned a little bit more, there is also, so just this is one of the statements, and it's not new, it's similar to what I presented already, that trainees learn best from these realistic, complex experiences. And I propose that some of that might be, that assumption might be driven by this model of desirable difficulties, which is certainly popular in the education psychology field. It has been brought into the scholarship of health professions education. And this diagram kind of summarizes the concept that there's this optimal intersection point of what a learner knows, what a task is going to require them to do, how difficult that is, and also what performance level they're expected to have achieved, and that is the desirable difficulty level. And conceptually, that is quite logical and appealing, but from what I've observed, this just opens a door to many, many assumptions about what constitutes difficult in a simulated scenario. So like I mentioned, people wanting to create these very complex movie-like, high action scenes is one way to translate a difficult situation. Not exactly what desirable difficulty is aiming to get at. So just we definitely need more scholarship on how to translate some of these models appropriately, and more practical steps for clinicians to follow when engaging in simulation-based education. And so just providing some idea of how we could translate that, and I've already mentioned some of these. So being explicit about learning objectives for each simulated scenario, and partnering that with some pre-briefing exercises and discussion amongst the learners. In those moments, they can state whether they feel prepared, whether there are certain things they know they don't know, or things they want to have the opportunity to practice more. Priming trainees to review the knowledge that they will need, involving trainees in planning what they're expected to learn, and what they will learn now, potentially even connecting it to what they might learn next at the next simulation-based education event or later in the curriculum. And making sure to include that debriefing component at the end. And then offering learners multiple opportunities to continue to practice the skills they were exposed to or introduced to in that simulation-based education event. And I'm coming close to the end here. So I welcome questions and discussion, and I'm just sort of closing with a few examples of some of the scholarship that I've created with my colleagues. So Dr. Matthew Sibbald was previously the Dean of our Center for Simulation-Based Education. He's now the Dean of our undergraduate medical school. And he and I have worked on some of this scholarship most. And one was a commentary on the value of choosing wisely, especially within the time of COVID when all learning and assessment had to be safe and with social distancing protocols in place. So that makes something like an OSCE impossible. And so there were some interesting, oh, I'm sorry, I just realized that the citations are reversed. But, and so there were some interesting innovations at that time that took the live in-person interactions that students had opportunities for and created more hybrid situations. So one thing that our center did was to have trained technicians with full protective equipment on in person in the lab in the center using the equipment, but then the learners and the faculty would join online and they would actually instruct the technicians to sort of participate, take on the role of the different actors in that scenario. So rather than the medical student actually doing the performance, they would describe what they think should happen next, and the technicians would act that out. And then another piece, expanding on that concept of surprising learners not being particularly effective. And last, this is just a bit of a preview building on that choosing wisely concept. Some colleagues and we conducted a modified Delphi process, which is actually the base of most of the Choosing Wisely campaigns. And we surveyed many directors from simulation-based centers across Canada. We took their input about their ideas of best practices for using simulation to enhance learning in the health professions. And then as a group of content experts, all of whom are scholars in this space, we refined a lot of those statements into these 4 high value and these other 4 low value statements. So high value being where the cost is relatively low, but the potential learning outcome is relatively high. Whereas low value, it would be the reverse. And so you'd end up just using resources without a lot of good outcomes for your learners. And I have included several other citations and publications of my work, which I'm happy to share this slide deck with people later on if that's of interest. And so I just added them there in case people are interested in having this shared with them. And that very quickly comes to the end of that.
Thank you so much, Jennifer. Listen to me now. I'm even confused with the names. Thank you, Sandra. I think that was very insightful and thought-stimulating as well. And it's amazing how your discussion actually fitted in beautifully with what Jennifer was sharing and some of the things that we shared throughout the years, which was our drive as a simulation group. So thank you so much for that and for sharing your ideas and for waking up early to join us. We really appreciate it. I'm going to open the floor for anyone who maybe has a question or a comment to Sandra, or who would like to have a discussion on some of the aspects that she shared. See, it's late-ish in the afternoon. It's after 4
Yeah, I know.
in South Africa. So,
I was
anyhow.
thinking that people have plans to go home and stuff like that. And I very much appreciate everyone showing up late in your day. Jennifer has raised her hand. So
thank you so much, Sandra. I was scribbling down notes furiously while you were talking. So interesting. Thank you. I was really interested in your point that I think it was from the Nelson study that students learn best from realistic and complex experiences. And I'm just thinking about, particularly, for example, in our speech therapy work, where it's very integrated, it is very complex, but to just kind of throw them into that, I feel like there needs to be a bit more scaffolding. So, I mean, maybe the Nelson article is talking about a different kind of scenario or different profession, but I don't know if you've got further comments on that.
definitely. So, sorry, there was so much information I wanted to pack into this. So a lot of the slides are me kind of skipping over some very complex concepts themselves. So the concept of desirable difficulty came from education psychology, and really what it was arguing for is that it's important to challenge learners, right? So don't just spoon feed them information, don't just stand there and lecture at them. It was challenging this idea that learners are vessels and you can just kind of pour knowledge into them, that they have to experience some kind of a challenge, be motivated to take on a challenge, and then that is what creates the best learning. And the concept of desirable difficulty was coined by some psychologists who they played around with very simple material. And so, for example, one effect that they were able to show is that the learners had better memory for sentences that were written in a font that was difficult to perceive. And so if they had to sort of focus on the words because it was like in this, curly font, or it was even somewhat faded on the screen, then later when they were asked to recall what they read in that experiment, then they had better memory for the ones they had to zone in on. So that's difficult to scale up to what health professionals have to learn, especially from an undergraduate student point of view. But that is the concept of desirable difficulty, and that is the origins of it. But people have tried to build on it, and so what I was trying to highlight is I've seen inappropriate applications of desirable difficulty in the creation of simulation or other education material, particularly in our med school. And so I've talked to clinicians who believe, well, I have to inoculate them for the stress of clinical practice, so I have to throw them into these very stressful, and I'm like, no, that's just filling them with cortisol and they just leave kind of a mess. Or I have to challenge them with a very complicated resuscitation where the equipment is blocked, and they have to be able to think about all of the factors that might be preventing this patient from breathing. And I think, why can't you just tell them, check your equipment? Why did they have to go in? It was a very expensive setup, and it was, and then there was a Confederate brought in, so they're paying the technician to be there to run the mannequin who's doing all the noises. Then there's a Confederate nurse who came in to act the part, and then the trainees come in and they're trying to gather information from other players in the room. So everyone's sort of paid to be there. And the only lesson was it's possible for the breathing tube to get blocked because when you're unpacking the sterile tubes, a piece of plastic can get stuck in there. And apparently that happened once upon a time, which is horrible. But I thought that's a really expensive way to deliver that particular. I think that is one case where you can treat the learner like a vessel and just give them that knowledge, right? So just some confusions around that. So there are very appropriate uses of this idea of getting to an optimal level of challenge and difficulty. And one reason this became really popular, I think, in our field is learners push back. So at some times, oh, that's too easy, or at other times their feedback is, oh, that's too difficult, or I just want you to tell me what I need to know, is the thing they sort of complain about. And so I think clinicians have been embracing this idea of, well, it's really good for you to be challenged and feel uncomfortable. You always have to be learning at your boundaries. So yes, all of that is correct. I think it's just planning out what desirable difficulty means for the learner given their level of learning and what they already know. Is that, sorry, may have
it's fascinating.
talked
I'm just
too
thinking
long to answer that question.
not at all. It comes back to that issue of fit for purpose and what is
Yes,
the rationale
absolutely.
for using the sim. I'm also thinking of some of my other work on communication skills training with students outside of sim, where what we found is that they really struggle with basic information giving. They're not at the point where they can cope with, okay, now there's a third party here and an interpreter and another big problem. So let's just focus on getting them to give information really well. And very basic skills actually can be very challenging to students. So thanks for that.
Yeah.
Really useful.
And actually, I realized, sorry, I'd meant to do this when I was starting off the talk, is like my observations and some of this commentary on assumptions is gained from working with clinicians in Ontario, right? So like a very particular context. Our medical students are often already coming in with a bachelor's degree or master's. Some of them are coming from another profession or with a PhD. So they are 25 years and up, right? And that is very different than in the UK. I have some colleagues I work with there where they're coming out of high school. And so they're even just knowing where the scholarship's coming from is important. You can't necessarily translate what works or what one scholar is talking about to your group. So I realized I don't know what kinds of learners or what level they are in Johannesburg, even like how they enter into the school system for the health profession.
They're also straight out of high school, most of them, unless they've gone through a graduate entry medical program. That would be the medical students. So Wits, our university, for example, runs one of those. I mean, that's a whole nother discussion, but I know some of us have been talking about this issue of we're applying adult learning principles to a group of students who actually don't have a fully formed frontal cortex until they're age 25. So we're expecting them to be able to cope with adult learning principles, but they're not at that level. And so the way that one scaffolds and supports needs to be particular to the age group as well. So I think that's a really important point to consider. Yeah,
absolutely. I do. That's also in the course. I spend some time explaining to our trainees that it's learning is always a developmental pathway. So whether you're in kindergarten or you're entering medical school or you're entering residency, or you're a senior nurse who's just entering a graduated nurse who's just entering the workplace, there's a developmental pathway that they're on, and so that does challenge this idea of an adult learning theory that they are self-motivated and all of that. Like, sure, they may be, but they're going to be very lost because it's just always going to be a brand new environment. Even the language can be challenging. So there is a citation in one of my slides which sort of talks about the sense of being overwhelmed when you're just new to a place. So you could be 36 years old, but if you're new to learning that topic or that skill, you don't know where to look. You don't know where to put your hands. You don't know what you're looking to listen for or what to remember. And so, yeah, using that model of sort of child development is better suited to our learners.
I think that also ties in quite nicely what you said, Sandra, about the priming and giving the student the information before, so that they can be assured that they know the skill that they are going to perform, and if needed, they can practice a bit more. So definitely some valuable insights shared. Are there any other questions from the floor? I see Alzana unfortunately had to leave. So unfortunately, we're not face to face, so I can't give you a tulip or a stroopwafel. So I met Sandra in Amsterdam earlier this year. So we would have given you some safari memorabilia.
Yes,
so maybe I'll bring you something when I come to visit. And then we'll share a picture with the group. But I really do appreciate both you and Jennifer. I really appreciate your time and there's a group of academics who freely share their knowledge, and I value that, and I think that's something it's a very, not only a useful skill, but it's a scarce skill, just to freely share your information and to freely share your knowledge, and I really value that. So I think I'm going to give you a round of applause, and just say thank you so much, again, for joining us. Yeah, it was really an insightful and thought-provoking discussion. And then I'll chat with both of you maybe afterwards, but I would like to make this recording available to the rest of the community who could not join us today. But I'll just double check that with you later on. But thank you so very much. So we are a little bit ahead of schedule, which is amazing. That normally never happens. So if everyone's happy, maybe we can move into the AGM. Sandra, you are more than